So I'll be talking today on URTI in its anesthesia concern. Day in and out, we come across pediatric patients whom URTI is very, very common. So in children less than 5 years, almost 6 to 20 episodes of URI may occur in a year. Approximately 200 viruses can cause symptomatic URTIs, and more than 95% are rhinovirus. Why we are concerned of these URTIs? Because there is the tachyphylline which is found in the smooth muscles, they are increased and they releases the factors, inflammatory mediators like bradykinin, prostaglandins, and interleukins, histamines. These are the perfect material for post-operative viral bronchoconstrictions. There is no single universally accepted definition of URTIs. Rather, it is the cluster of symptoms like rhinorrhea, nasal congestion, sneezing, productive cough, sore throat, and fever. The risk of perioperative complication is greatest in 3 days after URI, but it remains very, very high till 6 weeks. This increases the residual morbidity, and hence patient recovering from URTI also have similar or increased risk as that patient with acute symptoms of URI. And this is the trap for us. So we need to identify such class of patients. Perioperative complications to our list are laryngospasm, bronchospasm, breath holding, atelectasis, oxygen desaturation, bacterial pneumonia, reintubation, post-extubation croups, ultimately leading to unplanned hospital admission and parental burden of financial as well as emotional. So what we need to do is we need to identify such group of patients and do targeted PAC. Preoperative evaluation of such patient is very, very essential. Looking at the patient, the lethargic look, whether the patient is active or not, whether the secretions are active, thick, copious, or clear secretions, must be history to be taken in depth from the parents. Also, clinical examination is very essential, including systemic examination. When you look for systemic, apart from the respiratory findings, one should look for cardiovascular murmur or any abnormalities in the heart sound so as to rule out congenital heart disease. If the patient is detected as congenital heart disease, then our navigation is something else. So targeted PAC is very, very essential to identify and to classify all URTIs patient. As per the guidelines, we classify URTI into mild, moderate, and severe. The group of child who has recent history of URTIs, no current signs and symptoms within past 2 to 4 weeks are considered as mild URTIs. The child with running nose, dry cough, without wheeze and or fever, no irritability or lethargy for 1 or 2 days just before surgery are considered as moderate group of URTIs. And those with severe URTI like fever more than 38, productive cough, mucopurulent secretions, nasal congestions, sore throat or scratchy throat, wheezing, laryngitis, pulmonary involvement are severe URTI patient. So with mild or moderate, after detecting the URTI and categorizing it on preoperative evaluation, we can proceed for surgery or surgical plan in mild to moderate URTIs patient, considering the case-based selection. But in case of severe URTI age group, one must postpone for 2 weeks and reevaluate and reassess the patient. So the risk benefit is assessment is very, very important. Whether to cancel the procedure or whether to proceed with anesthesia is very important. The factors which will help us to give anesthesia are the child of older age, active and happy child with a good appetite, clear rhinorrhea, clear lung findings, short or minor procedure not involving the airway or major body cavity. And of course, our experience and our comfort zone to give anesthetize such child is essential. But at the same time, if the child is less than 1 year, having fever, productive cough, mucopurulent nasal discharge, malaise, poor appetite, lethargic, irritable, with all the clinical findings like rhonchi, wheeze, rales, and history of active reactive airway diseases, one must definitely postpone and should not hesitate to postpone the case. So blanket cancellation is, although a old school of thought, but it should be avoided for emotional concern, for economic concern, and as a concern of increased workload. But I will say at the same time, blanket consideration should always be there for every URTI patient. So our goal to for anesthesia management is to minimize the secretion, avoid or limit the stimulation of potentially sensitive or irritable airway. So less handling of airway, keeping proper depth of anesthesia will be helpful. Now, although this is a protocol for anesthesia management, but here I would like everybody to involve in active discussion and give your own valuable experience while dealing and giving anesthesia to such child. The ultimate goal of anesthesia management is to optimize the child conditions, hydration, humidification, bronchodilation, and suction the secretions. Either you give GA or regional, it is of your choice. But the proper optimization of child must be considered. There is one study which gives that glycopyrrolate does not reduces the incidence of perioperative adverse event in children with upper respiratory tract infection. Rather, glycopyrrolate is more frequently causing and parents reporting dehydration, flushed faces, hyperactivity, wheezing, and dizziness, thus ultimately increasing the admission time and significantly less post-operative nausea and vomiting. So it does not reduces the incidence of perioperative respiratory adverse event. Bronchodilators may be used either in the form of nebulization or total or IV, but combined corticosteroid and salbutamol to the adult patient perioperatively are more effective in minimizing intubation-evoked bronchoconstriction compared to inhale agents. So, whatever is the choice of your anesthesia, the depth of anesthesia should be adequately maintained so as to obtain the airway reflexes. Either you use inhalation agents or total intravenous or regional anesthesia. Even for regional anesthesia, some sort of TIVA is given. And if the patient is not in the appropriate depth of anesthesia, that local prick needle will also initiate laryngospasm. Extubation, yes, of course, awake or deep extubation as per your experiences. But remember, always look for the patient for a while, even after extubation, as this child are more prone for breath holding, desaturation, post-extubation croups, and all the anesthesia complications. Whatever sophisticated methods we have, whatever drugs we have, all the taking all the careful measures, anesthesia can be managed. But at times, even though with all the sophisticated technique, even in the confused state of mind, we use the GPS, and our GPS navigates us. Madam, it's a short case, 5 minutes case. We can go quick in and quick out. But at that time, we are in a trap, and we go merry-go-round over there. So the patient is minor, the procedure is minor, but remember, anesthesia is never ever minor. By choosing our path, we choose our destinations. So think twice and act wise before choosing your path. Your destination is a reward for safe driving. So the child with recent URTI are at risk of respiratory complication. Blind game can anytime turn out into blame game. Informed consent, good clinical judgment, experienced anesthesiologists are all crucial factors. Awareness and identification of risk factor is very, very important, whether to proceed or to tail the anesthetics as per your patient's condition. So now the ball is in your court, whether to provide anesthesia or to cancel the case. Thank you very much.